Welcome everyone. Thank you everyone for being here. Thanks Linda for the introduction. As I work at both the Survivorship Centre and at the Cancer Council, I welcome everyone to our new building at CCV and encourage you, if you're not already connected with the clinical network and with the Cancer Information and Support Service, to do that. And there are forms that you can complete to connect with the clinical network and with CIS. So after my little ad for the Cancer Council, I'll move on. There will be an ad for the Survivorship Centre in here as well. So I'm going to try and be brief, even though I think I've probably got too many slides, but I'll try to be concise and tell you very briefly, because I think everybody in this audience is familiar with the broad range of issues that we have in terms of providing ideal survivorship care, but it's worth reflecting on some of the challenges before we focus on the 6 pilots that have been undertaken over the last couple of years. We need to reflect on current clinical practice and then to think about the features of and some of the challenges in terms of providing ideal care to cancer survivors. And then I'm going to just give you a brief introduction around some models of care, what we know from the literature and what's informed the 6 demonstration projects that we're going to be hearing about and spending the bulk of time focusing on this afternoon. So the challenge, and I'll go through all of these points, the challenge really in providing better care for survivors I think is listed here. We've got a very large number of cancer survivors who can experience a broad range of issues, and we have incomplete and limited evidence and guidelines about how we should care for people best. We've got a limited health workforce, and we have to recognise that everybody's quite different. And so the same different people treated for the same cancer with the same treatments might have quite different needs, and we need to tailor treatment in response to that. So we have quite recent data in Victoria at the end of 2012. This is data from the Victorian Cancer Registry based here. At the end of 2012, there were 230,000 and a few, but very few more, Victorians with a personal history of cancer who are alive. Now, some of those people may be living with advanced cancer, but the vast majority of those people are cancer survivors. Victoria has a quarter of the country's population, so there are over 900,000 survivors in Australia, and you can imagine that's going to be very quickly that will get to 1 million. We know that this number will increase substantially by virtue of increasing cancer detection, better treatments, improving survival, and of course the ageing population. So this is data that will be available and published very soon, but this is from the Cancer Registry, indicating that the 4 major survivor groups in Australia are women who have survived breast cancer, men with a history of prostate cancer, and then survivors of melanoma and bowel cancer. And 3 of those 4, if you take out melanoma, are true of all developed countries. So the second issue is, of course, the broad range of issues that survivors can experience. And I think that everybody in the audience is familiar with this, that people can have very varied reactions to finishing treatment. Many people can feel quite lost and abandoned, and I guess that tells us this is a critical point, a critical time in the cancer journey, and many of the projects focus on this point. People can have persisting side effects, and they can be very varied, but often related to the type of treatment and the type of cancer. Emotional and psychological issues, including the fear of cancer recurrence, which we know is very common. It can be long-lasting and is sometimes disabling. Side effects that develop later, so-called late effects, which might include damage to organs such as the development of cardiac failure. It may include the development of a second cancer. This, of course, impacts on relationships and on family, impacts on work, finances, and other practical impacts. And I guess for a younger, perhaps more common in a younger audience, impact on school, study, university, etc. But we know also from the literature that people often find that although this has been a very difficult experience, many people find post-traumatic growth and find positives in going through cancer and cancer treatment. So many of you will have seen this before. We did some work at Peter Mac a number of years ago to see whether the issues experienced by survivors in Australia are the same as reported in the literature from North America and Europe, and they pretty much are. We use that information to inform the development of a DVD, which we will make available outside in the break. And also that led to the development of Cancer Council's first booklet for cancer survivors, which is now a national resource, which is outside. So the third issue, which I think can make it difficult in terms of planning treatment for cancer survivors, is the fact that we don't have complete evidence about what happens to cancer survivors. We know quite a lot about long-term quality of life and survivorship issues for some cancer types. Survivors of breast and prostate cancer, colon cancer, maybe lymphoma, but many other cancers not so much. Some treatments, if we think about treatments like trastuzumab or Herceptin, haven't been used in women with breast cancer for all that long. We don't know what the 20, 30-year consequences will be. We don't necessarily know strategies to prevent and to treat all of these consequences. So if someone is at risk of cardiomyopathy, how do we prevent that? How do we treat that to result in better outcomes? And we don't necessarily know models of effective follow-up. How often should we be seeing people, in what setting, with what tests? We have to recognise too that we have limited oncology workforce, and projections suggest that this will become more of a problem over the next 5, 10, 20 years. The fifth challenge, this is not all doom and gloom because we can tackle all of these things, but we need to be aware of them. The fifth challenge is, of course, the need to tailor treatment in response to a particular individual based on their predicted risk, not just the risk of cancer recurrence, but risk of other issues, based on their own needs and also based on their own preference. Some people might say, I want to have my care close to home, I don't want to come to Melbourne. Other people would say, you know, if I think that there's something else that I might be able to access, then that would be better for me. So our task, and it's not not necessarily easy, but one that we're up to, is to improve outcomes for survivors and carers. And that, I think of it as being two broad categories. One is about improved survival, and one is about improved well-being. We need to provide the most appropriate care and to use our limited resources both effectively and efficiently. So how are we going at the moment? Well, we do know from extensive work in the literature that current follow-up isn't necessarily evidence-based. We know that many people can be reassured, but they often leave with unmet supportive care needs. So if we don't ask about relationships, about return to work, about sexuality, how are we going to be able to help people? We know that rehabilitation is rarely considered, that there's inadequate communication with both survivors and with primary care, and it may not represent the best use of resources. So we do have some guidance though, okay? So we know things aren't ideal, but we do have some guidance about what we should be doing. And this is one of a number of guidance documents. It came out from the US Institute of Medicine. God, I hope that's not my warning. It came out from the US Institute of Medicine, otherwise I'm going to start speaking very quickly, in 2006. And if you haven't seen the YouTube video that I plug endlessly, please do have a look at it. It goes for 17 minutes. I know almost every word of it, but it's really worth looking at. So this is broadly what the IOM says are the essential components of survivorship care. So we should be thinking about prevention. We should prevent recurrent and new cancers, and if possible, we should prevent other late effects. If we can prevent infertility, prevent premature menopause, etc., then we should. We should be thinking about surveillance, and that's partly about surveillance around recurrence and new cancers, which we know often improve survival, but also around psychosocial and other late effects. We should be thinking about interventions, so dealing with medical issues such as lymphedema, sexual dysfunction, symptoms such as pain and fatigue, distress, which might be just as common in caregivers as people directly affected, and then concerns related to employment insurance and disability. And then we need to make sure that everything's well coordinated between primary care, hospital-based specialists, etc. So again, another of the other side of the balance, there are barriers to providing ideal care, and some of them we've talked about. We know that there is a lack of awareness of the broad range of issues that survivors experience. Some people point to the lack of evidence-based guidance, so what should we be doing? How often should we be seeing people? I think that there's limited, but there's definitely evidence of other ways that we can care for people. In the US, they say, well, we don't get funded for this work. In Australia, I think we have different funding issues. And it's partly about our funding models largely are around one-to-one, face-to-face review. And many of us would say, well, a lot of the time it would be more convenient and better care if we could just telephone people or send an email or think about group-based sessions. There are issues about workload burden, and also it's all very well to say it'd be great if we could have people seeing a dietitian and exercise physiologist, but we do need to make sure those services are available. Big eyes from Linda. So looking at some models of care, so this was a paper that was in Journal of Clinical Oncology in 2006 by Kevin Effinger and Mary McCabe, who I might say will be out here for the World Cancer Congress in December, thinking about models of care. This is a little bit busy, but I'm going to walk you through it quickly because I feel like I'm running out of time. I'm not. Phew, I'll slow down. Okay, so in the panel A, this is what we often happens for people affected by cancer. They know their primary care physician or their GP, and they have a relationship with their GP prior to cancer diagnosis, and at the time of cancer diagnosis, they see an oncologist, and often they pretty much get swallowed by the oncology system, and they're looked after by their oncologist for a period of time, and then at some stage they reappear in the community and to their GP. What these authors suggest is that would we be better off having a more formalised shared care program in which the GP assumes secondary care during the time of cancer treatment and for a period of time afterwards. The oncologist then transfers care to the GP, but continues to have some involvement. And critically, there needs to be good communication around the time of cancer diagnosis, particularly relating information about cancer diagnosis and planned treatment. When people complete treatment, we should be thinking about a provision of a survivorship care plan, which you'll hear about a lot this afternoon, which summarises details of the cancer, the treatment and plans for follow-up. And then there needs to be a mechanism for ongoing communication when the person's being primarily looked after by their GP. They also talk about some other models of care which might be applicable for some people. So this is in an academic cancer centre. Again, the GP is secondarily involved during cancer treatment and in follow-up. And the care might be primarily with an oncologist, by which I mean hematologist as well. And then they might have ongoing review with a nurse practitioner. This is very much the model at Memorial Sloan Kettering. They've recently come up with the idea that they might discharge people. Ooh, careful. Another model, and this is something we're familiar with when we think about late effects clinics. For some people, they might have very high-level needs, require a multidisciplinary team, and these people may be better off having ongoing management through a long-term follow-up clinic or late effects clinic, but with ongoing care in primary care as well. So they're models to think about as we reflect on some of the models we're going to hear about this afternoon. I want to briefly review some literature about follow-up in other settings. So a systematic review from a few years ago, there have been others, that compares follow-up in the community with GPs versus traditional hospital-based follow-up, and basically indicating that at least in some circumstances care is at least as effective, probably associated with better satisfaction and is cheaper. A couple of randomised control trials, just to mention, Eva Grunfeld is an academic primary care physician based in Toronto. She did a couple of randomised control trials comparing hospital-based follow-up with GP-based, community-based follow-up in the UK and in Canada. And as I've written down the bottom, associated with similar disease outcomes, similar quality of life, greater satisfaction with community-based care and lower costs. So that tells us that at least in some circumstances we could certainly think about care in the community. Likewise with nurse-led review versus physician review, again, at least in a number of studies that were examined, at least as good disease outcomes and probably better satisfaction. One example, just to again indicate, doesn't have to be hospital-based, it doesn't have to be medically led. This was a study that again was for follow-up of women with early-stage breast cancer, showing that follow-up, which was nurse-led and telephone-based, was equivalent to hospital-based review. ASCO, the American Society of Clinical Oncology, at the beginning of last year, came out with a statement about how can we bring about better care of survivors. Again, first author Mary McCabe. They talk about the need for better clinical guidance and that ASCO will work to achieve this. They talk about pursuing different models of care, and that's the major focus for today. Assuring high quality care, education for providers, as well as for survivors. We need to be doing a lot more research, and there needs to be some ongoing efforts around policy and advocacy. In the UK, I think that the UK has done a lot of great work, and that has informed the work that we're doing in Victoria. And I'm just briefly going to highlight some of what they believe to be emerging principles for the future care of adults with cancer, or not adults with cancer, all people with cancer. So one of those principles that you will hear about this afternoon is around risk stratified care. So you can imagine that if someone's had a very low risk cancer treated with a simple excision, for example, the issues that that person might experience are likely to be quite different to, for example, if somebody's been treated for a head and neck cancer with surgery, chemotherapy, radiation, has ongoing issues with speech, swallowing, diet, etc. So we need to think about different pathways of care based on risk of a number of issues. They also emphasise the need for a care plan and a treatment summary, that we need to provide survivors with information and education. The idea of remote monitoring, so people might be able to have ongoing blood tests or scans without necessarily needing to see health professionals. They might get an all clear, or they might be informed that they need to have further investigations and be recalled, in the same way that we do with breast screening. We need to obviously make sure that there's good care coordination, that people can get back into the system if they have issues, and ideally people should have a handheld record. So I think many of those points you'll hear again this afternoon. So I show this slide a lot, but I do think it's important. So these points here are around assessment and care planning. And so what they suggest is that we need to sort of take stock at the end of treatment. And some people will transition from treatment to living beyond cancer. And the main focus of, and they might remain well, and the main focus of treatment might be around surveillance. They need management of acute side effects and the building the capacity to self-manage. But they need to get back into the system if they have issues. And so these people might be able to self-care with support and open access. Other people transition from treatment to living with cancer still, or living beyond cancer but with consequences. These people might have greater levels of need, require greater level of intervention, and might need to be more appropriately managed in a formalised shared care arrangement or in a complex case management, such as through a late effects clinic. So this is quoted from that ASCO document, and forgive me for reading it, but I think it's important. Ultimately, the testing of various models through demonstration projects is needed to identify optimal methods of care. And then we need to disseminate this information and education on these models to both providers and patients. And I kind of think that's what we're doing today. We're sharing the work of the demonstration projects. So that leads me into the Victorian Cancer Survivorship Program. This was mentioned in the previous Cancer Action Plan. We'll establish a statewide program that trials patient-centred models of survivorship care. And as Linda mentioned, that's funded by the Department of Health with an initial spend of $1.7 million, which has been extended a little, and that's funded 6 two-year projects that we're going to hear more about today. They all focus on the end of treatment, and they're all linked with primary care, and they represent and deliberately represent a range of cancer types, geographic areas, models of care, and age groups, and that was quite deliberate in the funding of these projects. This is taken from a newsletter that we did last year, but it basically explains what we're trying to do. I'm going to skip that because I know I'm running out of time. I'm going to tell you very briefly about the Australian Cancer Survivorship Centre for those people who aren't familiar with it. As Linda mentioned, we have funding from the Pratt Foundation and the State Department of Health since 2009. We're a small but amazingly impactful team which funds a small staff. We have a dual focus because of our dual funding on both Peter Mac and the whole state. We don't provide direct clinical services, but we work with all of you in this room and many others to try and improve care for survivors. Outside, we've got our year in review that explains a little bit about the work that we've been doing. we also have outside our strategic plan, which explains what we're currently doing and what we will do for the next few years. I won't go through that in detail because I'm running out of time, but please pick that up. We, of course, have a website, which we hope will be useful for you. We've got the strategic plan here. This is the promo for today. Information about the VCSP here, and information for both survivors and health professionals. Slides available on the link. Thank you, Linda. So these slides will be available. My final slide. So our challenge is obviously to provide better care for cancer survivors, recognising that it is a challenge. We've got a very large number of survivors with diverse needs and a limited workforce, but we can, I'm very confident, do better, and we're going to hear about some projects that are shaping the way. We need to evaluate a range of models that we'll hear about, and I think that we have from all of this work a number of key principles and learnings to shape the future care of survivors. I'll leave it there.